I know. Well, first, thanks everybody for putting this on. I appreciate doing this remotely. This is kind of unique and fun. I think we're going to see a lot of this in the future. So, you guys have been pioneers in this stuff. Um, I have no disclosures for this part of the presentation, or really any of them. But the discussion really is transforming perfusion practices into high reliability organizations, and it is a mouthful. I think it revolves a lot around good topics in this time regarding safety, quality, even in the COVID, thing, all these different things we need to be doing. But what really is a high reliability organization? So it has to do with engaging in high risk endeavors, with low incidences of adverse events. So I think we can kind of all relate to those kinds of things, and it revolves around culture and processes. So what we're used to from the operative environment, it's
Hey,
not dissimilar from other
what do you
industries. As
mean
an
shout out,
example,
man? You guys, you're part of it. Yeah, yeah.
sorry. Oh, um, so some of the examples you might think, aircraft carrier decks, nuclear power plants, air traffic controls. These are sort of the classic ones you've kind of heard of throughout the industry, particularly most related to healthcare. The airline industry with crew resource management and all those different kinds of things. Lots of studies have been done, particularly in these particular areas, in this classical sense, and their unique opportunity was to the ability to succeed simultaneously maintaining reliability, performance, and safety in extremely high levels of care or service. So, I mean, that's how they became highly reliable. That's where the term came from. So, how does that really play into what we do? Based on how many times could we do this operation or whatever we're doing, and without a failure or a catastrophic result. So examples in healthcare are abound. You can imagine what we're doing. So do we qualify? I think it's pretty interesting as perfusionists. I don't know if we look at it this way. How many times could we operate the heart lung machine without a catastrophic area and any failure? And I think we need to really talk about what those types of things. I mean, catastrophic, we understand. But failures I think, are something we should review a little bit more in depth. So this is something, and we talked earlier. Quint Studer's pretty prominent in this area. High reliability organizations are organizations with systems in place that make exceptionally consistent in accomplishing their goals and avoiding potential catastrophes. So, what kind of environment we are in? I would say high risk environments. Are they hyper complex, interdependent teams? Extreme hierarchical differentiation. There's multiple decision makers. Need for frequent immediate feedback, or are we compressed time constraints? So I think that's a perfusionist world. I think a lot of you would agree. But not performing well in this industry could lead to fatal results. So, I mean, I think we start as perfusion departments and groups and different things. I think we need to start recognizing this sort of care. If you, again, compare it to the airline industry, there's, how many times do we get on a plane with minimal accidents? There's a lot of literature. I heard statistics before where, medical errors in the US would be like a plane crashing every day, if you can imagine that sort of synergy. So in our world, obviously it's not as prevalent, but how much do we really know? Because, what do we measure, and how do we measure our perfusion outcomes? So I think that's something we could talk about in a little bit too. But what are 5 traits of high reliability organization, and what makes an HRO an HRO? So let's look at what it does and how we can start to relate to it as a perfusion practice. So first is the preoccupation with failure. So how do we look at those kinds of things? There are extremely rare events, so there's really limited opportunities to learn from trial and error. Have been, possibilities of failures or failure abilities that that allow us to adapt to a crisis. I mean, where can we learn from them? Finding and fixing problems isn't just an individual issue, and that's sort of a hallmark of an HRO. It's really, it's the team approach. Finding and fixing problems. I mean, is it led by a leadership from your chief perfusionist or somebody in your department? And do you report errors and failures in your practice? near misses. I mean, those kinds of things. So a lot of those things in a high reliability organization would be reportable and highly valuable opportunities to improve care. This is some from for ECRI, Agency for Healthcare Research. The absence of errors and incidents leads not to complacency, but a heightened sense of vigilance for the next possible failure. So every failure needs to, failure analysis. HROs view errors, or however unrelated they might be, to have circumvented the whole event. So dysfunctional things like reduced attention, complacency, like I didn't do my checklist, nothing really happened, or you talk about like Benson backwards, nothing really happened, you discovered it. That was a failure if you made it to the point where you got on pump and you fixed it. So those types of things are interesting. And the difference between what we're doing, and should perfusionists be encouraged to miss and report errors? I mean, some of the challenges, the fear and shaming of reporting errors, like you have a new grad or young guy, or even a senior person, how apt are they to go to their leadership right after a case and say, hey, I had a near miss. I didn't hook up the O2 line, or I just didn't do that. Is it pronounced and encouraged to do as a team? And, is it looked at in that regard? As an example, in the airline industry, they do what's something like indemnity reporting. So it's an accolade that you actually discovered something that was bad and you reported it, and that was great. In healthcare, it's a little bit different story. So it gives you a little bit of stress. Something I think we'll talk about a little bit as well, as far as the culture of safety. Reluctance to simplify is a second trait. So trying not to look at every single aspect, try to reduce the temptation to look at things as, that's acceptable, that was near, it didn't really matter. Resisting that kind of temptation is important. How many people here, unfortunately, it's hard to do it from a remote sense, but root cause analysis. I mean, how often do you really look at those types of things at all aspects? So really reluctant to simplify what you're doing. Not cutting corners is really important. The third, sensitivity and vigilance to operations. I'm referencing a lot of things that we like to do as an organization. I'm sure many hospitals and other groups do as well. It's like, do you play close attention to and make awareness of what's not working, what's not? Do you survey your clinicians, your team members, and those kinds of things? Don't make assumptions. You should ask a lot of questions. And as we continue on in this discussion, the next one, using data to make decisions and track outcomes, I think is really an interesting topic. And what that really means in sensitivity to it could be debated for sure. We talk about compliance data and analytics. Talk about what we do in many places, like your performance improvement and compliance measures. How often do you measure it? What are your compliance measures? As an example, avoidance of hemodilution, those types of things, glycemic control, hyperkalemia, and then reporting as a multidisciplinary team. I think the most important thing coming out of this comes to communicating and, integrating the team and not just individuals, integrating frontline team practices that improve communication, handoff tools, pre-incision briefs, and all those different things. In my next talk, we'll talk about how technology plays a role in that. But I think these are all things we can be doing today without that, just making it better as it goes moving forward. Number 4 would be commitment to resilience. Imagining every scenario and training for it, knowing how to respond to failures, sensitivity to operations. So really training, disaster drills, change outs. I mean, I'm not sure how many people do it today in their practice, but we all studied it from the board perspective. But that emergency air embolism, how many times you may have discussed it in your team meeting, but how many times has the entire team got together with anesthesia and the surgeon and practice it? At what regularity? So the hallmarks of these kinds of things from HR is not being error-free, but the errors don't disable it. And that gets into what I'm saying about these emergency management, whiteboard simulation, and practices. Those types of things we just discussed. The last one, the fifth one, would be deference to expertise. And I think this is really an interesting topic related to perfusion. We have a lot of senior people that have been doing it for quite a long time. And you may be at your facility that doesn't do it much. We've heard different talks on, I think it's interesting with ECMO and VADS and all these different modalities that frankly, not a lot of people have experience with. ECMO is a great example. And I use that here as ECLS. I mean, we have a lot of people that do ECMO and probably, I guess probably have no business doing it. Or, we look at ECMO as a program, not just a procedure. So, and oftentimes, those experts aren't the most senior person in the room. So, I mean, we have to, utilize the people. You may have some people with expertise. They might not be the surgeon or the intensivist or the nurse or perfusionist. So it's really important when it relates to these kinds of things in preventing failures and those types of events. You guys can read this. So, the greatest knowledge situation may not be the person with the highest status or seniority. So really, really important to think about. This actually creates a lot of big challenge, though, in the healthcare arena. So as an example, when you talk about like airline industry, career resource management, it's really team driven. And in those kinds of situations, they're really in the airline area, it's more of a first name basis kind of thing. That really doesn't exist much. In some places it does in those highly, cohesive teams. But in healthcare, it's something that we're working towards. Even our own organizations, from director or chief, or people stuck on titles and whatnot. So I think flatness in the organization, or at least the clinical hierarchy, needs to be looked at and examined for performance. Also, things like example in the airline industry, conversely to healthcare, they look at human factors: stress, fatigue, sleep deprivation. Those are interesting things. Time on duty, hours between shifts. So if you're short-staffed, I mean, is it a safety issue? And could this be some things that we look at? It's fairly, pretty common for us to, miss meals and, all these different things, extreme multitasking, distractions, interruptions, making that rule that nobody should have cell phones in the OR. I mean, that's debatable with technology today. So it's kind of used. A lot of hospitals are getting away from pagers and using those things. Even some of the technologies we use can use mobile devices. So it's trying to mix things using technology that's less distractive and more useful. And again, getting back to that whole team approach. I think a really interesting thing, and I keep talking about the airline industry, they use a lot of tools for error management. And an example is this 3-pronged tool. And it's really avoidance is the first thing. It's a 3-level pyramid, so to speak. So it's the avoidance of errors. I mean, checklists, safety devices, policies and procedures, all those things we believe we have. Having that whole sterile cockpit idea related to the airline industry during a limited distraction or no interruptions. The next phase would be like trapping like incipient errors, like the 2-person verification philosophy, like as a guideline for AMSEC as an example, or that's why we do with blood verification. Those errors that can just simply happen and have redundancy. So another example would be repeat from a communication with your surgeon. That read back from the surgeon, like flow down and flow up and such thing. And then the last thing in dealing with error management is frankly the mitigation. So we're human, errors are going to happen, but need to be training for scenarios to mitigate the adverse events from those errors. And that gets down to whiteboarding, simulation, and reporting those near misses so other people can learn from those kind of events. A great way to talk about this is another model by John Reason. It's called the Swiss cheese model. So the best way to example is we put up a lot of barriers, and this is an example of a slice of cheese. So there's many layers for policies and procedures. Our culture is an example. We have what we do, individual teamwork, how we communicate, the individual themselves, how they perform, their knowledge base. Are they complacent? And then the technologies that we have, all these barriers are in place to prevent disasters. But when those unique things align, there tends to be an event that, if the policies are unclear and there's poor standardization, communication failures, like I mentioned, distractions, inadequate training, and then, poor, clumsy technology, maybe missing PMs, or I didn't engage my safety device. This is where I'd love to have one of those polling tools, is that how many people actually use all the safety devices in their pump. And we talk about later in practice variation, but a lot of people say, I don't need it. Oh, it's cumbersome to me. In a high reliability organization, that relentless pursuit of safety, that would not be acceptable. And when these things align, essentially what you have is, an adverse event, a system failure, and there you go. So how do we do and what do we change these, become a critical component? So building your safety system, we need to understand that safety is everybody's job, and we need to enable like all levels, not like a top-down approach. So even your newest person, especially a lot of our newer graduates and new team members, or, people from other institutions. I know a lot of people hate hearing, well, we used to do it this way at wherever. So, and I know that's sort of a very interesting cultural dynamic, but everybody has something to contribute. And again, humans are fallible. We need to be able to design our systems and to protect our patients with continuous improvement and to actively engage with staff across multidisciplinary organizations, not just live in silos. So it's really about hardwiring our culture of safety. So that really needs to be where we start. So how does your perfusion department become a high reliability organization? I mean, these are some of the simple things, updating your policies, your competencies, strict maintenance to your equipment, using your safety devices all the time, yearly audits of your program, how many people actually go through and do those types of things. Sentinel event incidents reporting mechanisms. I mean, I don't know how many perfusion programs or groups are involved with their compliance and quality officers. It should be a standard. Looking at your pump record, and this is something we'll talk about with technology. What's on there? What do we use it for? A lot of people use their pump record for a scanning tool. So that's certainly relevant, but can be distracting. In services for every device that you use and at what frequency. And we can't stress enough communication. And so on. Well, I don't need to read it for you, but really developing a strong culture of safety meeting and really your comprehensive emergency management training. I think if you do nothing else, you really need to have this as part of your program. That's something you can take away tomorrow, go back to your group and start really working at these things. And how would you measure success in that? It's really 100% success in every scenario. Making sure everybody's comfortable and familiar with new devices and the procedures that they're using. Because you know what? They constantly change. Everybody, every other day you got a sales rep bringing in something new for the physician to use. How does that impact your care? Does it impact your care? It's not just the devices we use. And uniform communication across the event. This is where like team drills and simulation really start to play a big role. And multidisciplinary, and a successful multidisciplinary planning and developing each mock scenario and changing them up. So it's not the same exact scenario for every person. So it becomes repetitive. There's sort of checking the box, and that's where complacency develops. In assessment metrics, dedicating non-clinical time to perfusion and development, and implementing these things outside of our clinical care. So at least our philosophy, and I would assume a lot of other folks on the meeting, it's not just pump and run. I mean, you have duties and responsibilities outside of your clinical practice to make your clinical practice better. This kind of meeting being one of them. Failure to identify these correctable gaps in knowledge, you increase your risk tremendously. I don't need to, I'm not sure how I'm doing on time, but not too bad. So some of the examples, I think you guys understand all these things, air embolism and stuff we've common currently, but things that we don't misplace, aortic cannula, those things that happen, one in a significantly few, but is a deleterious outcome. Again, we can have some technology to help us with this, but we need to be aware of it. And as we get more and more monitoring around the rooms and all these different monitoring devices, you're talking about BIS, near infrared spectroscopy, all these different things, there's something else to look at. So I think you need to take into account all the information. It just makes it more challenging. I think from an HRO perspective, a lot of folks do it from a personal approach, to a systems approach. So don't focus on the unsafe acts of one person and laying blame. It's really, if it happened, it's the responsibility of the team. So, we all have mitigating factors and those types of things, and errors are seen as a consequence, not the cause. So it's process controls and those types of things. And again, to building those, slices of cheese, increase your safeguards, shrink in the holes. So making it, remove the failures and making them blameless, to blameworthy, and learning from the opportunities. I think another really quote, same guy from the Swiss cheese models: "We can't change the human condition, but we can change the conditions under which we humans work." So we have the opportunity to really affect what we're doing and change those environments. So they're committed to excellence, really, and failure is an opportunity. Refraining from simplifying, emergency management and deference to expertise, and vigilance to sensitivity to operations really result in quality and safety. And that's really where we're getting to with a high reliability organization. So I think we all should act and strive to be one. I know it's something we strive to in our organization, and I know many others do in hospital departments. But I think getting out of our silo and really developing the team is really important. And that'll relate a lot to what we're talking about next as far as technology and everything else. But really, it's statutory compliance, error management, process improvement, and regulatory adherence. So all those things really come into a high reliability organization and what you can do from a perfusion department. That's kind of what I have. Any discussion on this part of it?
Yeah.